In today's video, we're going over what physical therapists need to know about patellar and quadriceps tendinopathy. What's going on, guys? This is Dan Pope and Kevin Coughlin from Fitness Pain Free. We're physical therapists. We're here reviewing the literature, summarizing it, giving our kind of practical experience. Or what are we doing here, Kevin? We're helping people. We're putting this together, summarizing it, and trying to make you an incredible clinician. How are you doing today, Kevin?
I'm doing really well. It's a beautiful morning. Excited to talk about tendinopathy of the knee. Yep,
Yeah, that's probably one of the best things you can do on any given morning is to talk about knee pain. So
I
I'm
agree.
pumped.
Yep.
Let's get this baby rolling.
All right. Kind of related, unrelated, but I thought this was really helpful. Just I remember going through school and hearing all these different terms and being so confused about the differences between all these words because they sound very similar. So I thought this would be a good place to just kind of give a brief definition of each of these. So we have tendinitis, tendinosis, tendinopathy, and tenodesis.
Mm,
So yeah, they all sound very similar. In terms of patellar and quadriceps tendinopathy, the research has kind of shifted to that term because tendinitis suggests that there's an active inflammatory process, which there may be. I guess it seems like we've kind of shifted back and forth on this a little bit. But I think the reason they really started driving this home was because the primary treatment is no longer rest and NSAIDs and that type of thing. It's not primarily an inflammatory condition. So when you see itis, tendinitis, we're thinking an inflammation of the tendon. A tendinosis is a more degeneration of the tendon. So if you look at it under imaging, you see changes to the tendon, and it shows that it's degenerating a little bit. Tendinopathy, as I said, this is the clinical term that we're using for this type of tendon pain. So that's the key thing is it's a clinical presentation of pain in a tendon, resulting in dysfunction, and that could be with or without structural changes. So when you see it in the clinic, that's what we're calling it. And then more unrelated, but the tenodesis is a surgical treatment option where they change the site of the tendon from one part of a bone to another. So just I thought that would be helpful just to clear the air here of these different terms because they all sound so familiar.
Pardon the interruption, but I have something that's going to change your life. It's $1 million. No, it's not. But it's an evidence-based guide to patellar tendinopathy. Staying on top of literature is hard. It never feels good to have a patient in front of you with a specific condition and you haven't read through the research recently. Well, this bad boy is going to help you out. It is an evidence-based cheat sheet for patellar tendinopathy, and my promise to you is I'm going to catch you up to date with the literature on patellar tendinopathy under 10 minutes. We go over definitions, anatomy and biomechanics, differential diagnosis, risk factors, prevalence, clinical presentation, recurrence rates, how to diagnose this condition, and all the best treatments for this common problem. Best of all, it's 100% free, so go ahead and click on that link in the show notes in the description and get your cheat sheet on how to best treat patellar tendinopathy. Now back to your video. Like that, Kevin. It's good to just kind of get a little refresher on that. It seems like over the course of time, we now know that patellar tendinopathy is not necessarily an itis, although I'm sure we'll talk about this a little bit later. There's a little bit of inflammation there, but it's not quite the same as a full-blown tendinitis. That being said, usually with the tenodesis, you see that in the biceps tendon, not necessarily in the patellar tendon, but good to know the definitions. Unless you're doing patellar tendon tenodesis in the clinic somewhere that I don't know about.
All right, so a little more background here just on the patellar and quadriceps tendinopathy is that they can be debilitating and they're very, very common. Like if you work in an outpatient orthopedic setting or a sports setting, this is something you're definitely going to see, both of these things. So just in terms of prevalence a little bit, one perspective study, which looked at elite athletes competing in soccer, long distance running, volleyball, orienteering. I think that's Dan's favorite sport. Basketball and ice hockey noted that 50% of the athletes with patellar tendinopathy were forced to retire from sport. And when asked why, they noted that their patellar tendon pain was one of the reasons that they retired. So, just interesting. I think when you are competing at a high level, this is something that we'll see pretty frequently. We'll touch on prevalence a little more coming up, but and then in terms of pain location, so The patellar tendon pain location, you kind of see it in, I guess, a couple places, but most commonly is the inferior pole of the patella. So if you kind of palpate the patella and you work your way down to the very bottom portion, that inferior pole, and you poke it pretty hard, a lot of people will have symptoms with that and they'll complain of pain there. You can also have pain a little bit lower at the kind of tibial tuberosity for the tendon inserts, but not as common, only 5 to 10%. And then clinically, I've seen a lot of kind of mid-substance pain as well. Like if you're just squeezing the middle part of the tendon, that can be painful. But inferior pole for sure seems to be the most common location of pain. And then in terms of that quad tendon pain location, where on the upper side of the patella, so the superior border, and you'll see that most commonly as the pain location for the quad tendinopathy.
Just a little anecdote. I tend to see a lot of quad tendinopathy in my orienteering sporting population. Actually, I have no idea what orienteering is, but I do actually see a little bit more quad tendinopathy than I thought I would. And I don't know if that's because I see more lifters. I actually tend to see probably more tendinopathy of the quad tendon than the patellar tendon. I think that's because of the population. If I was working with volleyball players or basketball, I bet you it'd be more patellar tendinopathy. I have no idea. Just thought it was a little interesting anecdote that I tend to see that a little bit more.
All right. How do we diagnose this thing? So for patellar tendinopathy, I think it's relatively simple. There are some other things we'll talk about differential diagnosis, but there's localized tendon pain. And as I said on that previous slide there, usually on the inferior pole of the patella. So the pain, it's not a very diffuse pain where you're getting pain all over the place, like patellofemoral pain can be. It's really right on the patellar tendon and that inferior pole. You'll hear, or the patient will say, that pain increases with movements that put increased demand on the knee extensors. So when you're really loading the quads, we tend to see more pain with those types of activities. And activities that load the tendon at a very high strain rate. So I thought this was interesting that a body weight squat imparts a load of 4.8 times body weight. So just something to consider. The strain rate of that is 1 to 2 body weights per second. Kind of hard to wrap your head around this, but just compare that to spiking in volleyball. It imparts a very similar load of 5.2 times body weight, but it does it at a strain rate of 40 body weights per second. So it's really that high strain rate you could think of as the speed of the movement. And that's really what's going to load that patellar tendon more. So you might hear, someone say they have some patellar tendon pain with squatting, but more commonly it's going to be those high strain rate things. Someone that is jumping explosively, more likely to be a source of pain. They might describe a warm-up sensation. So a lot of times the person will say, when I'm starting out my activity, a basketball player, I'm in the layup line to warm up. It's pretty sore, but as the game progresses, it gets a little bit better. And then they may show that 24-hour period where it's actually worse if this is kind of reactive. But you want to ask about, does it warm up? Kind of helps you rule in a tendinopathy. One test you'll see a lot that I think is very easy to do and seems pretty decent. I didn't find any sensitivity or specificity with it, but just doing like a decline squat test. So keep the torso really upright, squat down. Does that bother the tendon? And then some jumping with that, maybe to see if that bothers the tendon. And then imaging, probably not something we need to do to diagnose. There may be some degeneration showing up on the imaging. We do find that if you don't have tendon pain, but you do have tendon degeneration or tendinosis, that you do have an increased risk of developing tendinopathy. But it's not something we're going to use diagnostically. So just keep that in mind.
I think what you said about the strain rate was really important. And yeah, those numbers are tough. And I kind of struggle in terms of using the word strain or stress or load, what you're actually doing to the tendon. And it gets a little bit complex. But I think the takeaway here is that the faster you move, generally speaking, this is going to stress patellar tendinopathy, has a likelihood of creating it and or exacerbating it. And I think where it's important from a treatment perspective, and we'll get to this a bit later, is if you do an isometric, there's obviously no movement. And this is usually pretty well tolerated. And if you move slowly, think of a heavy, slow load, usually that's tolerated a little bit more than a faster movement speed. And then think about plyometrics. Usually that comes towards the end stages of rehab. So what we're trying to do is dose exercises starting with slow or no movement and then progressing to faster movement for this exact reason.
All right. And then in terms of diagnosing quad tendinopathy, Dan, I think your input here would be good too, because you see this, like you said, pretty often, but you'll get a localized pain, like I was saying, at the superior border of the patella, so just above the kneecap. And it also is going to show increased pain with movements that increase demand of the knee extensors. So kind of those quad dominant movements that we might see in the gym. And similarly to patellar tendinopathy, pain increases with activities that load the tendon at that high strain rate. So that very high load, high speed. Again, it will be tender to palpation, similar to the patellar tendinopathy. And as most tendons do, they might demonstrate that warm up effect. So something else you might want to listen for is, does that seem to be happening?
I think you nailed it. I find that it's very similar than to patellar tendinopathy. If you do have a lifter, excuse me, usually it hurts with kind of squatty movements or some of the Olympic lifts. So as you descend into a squat, the knee starts to hurt. It kind of looks and seems a bit like patellofemoral pain, whereas where you descend a little bit deeper or when you add more load, it tends to hurt a bit more. And the pain tends to be just above the kneecap. So initially, people say kind of this anterior knee pain. They kind of put their hand on their kneecap, and you start thinking, this seems like patellofemoral pain. But if you start poking a little bit more, you're like, oh, this actually seems to be a bit above the patella. And in terms of kind of differential diagnosis and then treatment, usually, at least for patellofemoral pain, we can start with a little bit more hip dominant movement. But for some of these quad tendinopathies, I want to start probably thinking about loading the quad earlier in rehab, although I bet you hip dominant movements are probably going to be helpful for quad tendinopathy too. I just don't know that the literature is robust as with the patellofemoral research, right?
All right. And then just, when we're trying to diagnose this thing, there are other diagnoses I think we want to rule out. So anterior knee pain, there are a few things we could be thinking about. And patellofemoral pain is definitely one. So you could go back and listen to our episode on that we did pretty recently. I think that was a couple good episodes.
Banger.
Osgood Schlatters, something that you'll see pretty often in the younger population. So this is a pain of the growth plate where you have your tibia tubercle, and it's kind of that bump on the proximal tibia where the tendon inserts. So if you have someone who's above, probably the age of 15 or 16, it's kind of less likely that this will be what's going on. But something to keep in mind in younger folks, because it can present very similarly and be pretty painful. Very similarly, Sinding, Larson, Johansson. So this is the same type of growth plate issue, but this is at the inferior pole of the patella. So just keep that in mind as well. If you see a younger population, this could be the source of their pain, and you're going to manage it pretty similarly, but just know that that could be a little bit different, what's going on. And anytime we have anterior knee pain, we want to check for swelling and make sure that maybe they don't have some meniscus or ligament involvement, something intra-articular. With those, you're probably going to hear about a traumatic incident sometimes causing their pain. You might see some swelling and that type of thing. In runners or, other sports where you're doing a lot of impacts, you want to make sure you're ruling out a femoral bone stress injury. I think this will be relatively easy because it's not going to be pain, right by the kneecap, the inferior pole. So you've really used the location to differentiate that. And then Hoffa's fat pad syndrome is another anterior knee pain structure that can give you that anterior knee pain that you want to be on the lookout for. So that will present relatively similar, but with that, they tend to get pain with kind of forcible end range knee extension. And the mechanism's a little different, but make sure you're kind of considering some of those things when you're going through your eval. With the patellar tendinopathy, it's really going to be pain with loading. They're not going to have swelling. They don't tend to have pain at rest. This is something that hurts with activity. They won't have joint line tenderness. They may or may not have joint laxity, but that won't be caused by the patellar tendinopathy. So, keep those things in mind. I think it's fun to practice ruling those out. And feel confident in the diagnosis.
All right, and I think that what you had just said about the progressive loading, one of the things I like to do, which I think is beneficial, is that you can do some hopping. So some double-legged hops, maybe some pogo jumps, starting kind of lower jumps, work your way to higher double-legged jumps. And what you should find is that pain goes up as that intensity goes up. You can try some lower level single-legged hopping, which again is a little tougher than double leg. Then you go to a higher single-legged hop. And you should just find that pain gets worse, worse, worse over the course of time. For something like a bone stress injury, you may find that the pain is kind of severe with everything. It doesn't change too much. Although I think that the more strain you throw on anything, it's probably going to be more painful if you do it at a higher intensity. But that is one of the hallmarks of a patellar tendinopathy. It's just that the more intense the exercise, usually the more pain that you get. If you guys like what you're learning about so far, then the next logical step is to sign up for the Fitness Pain-Free mini course. I've made an absolutely free mini course, and we go over 4 vital lessons for coaches and clinicians. The first lesson goes over how traditional schooling has failed us. Now, I'm actually a really big fan of education, and I think that physical therapy school actually prepared me pretty well to work with the average person. However, I really didn't learn how to work with the population that I want, which is people in the strength and fitness world. So I'm talking about powerlifting, bodybuilding, Olympic weightlifting, sport of fitness, and really people that just love working hard in the gym. And really my goal with the mini course is to help you understand how you work with this population to get them out of pain and keep them training. The next lesson is 7 reasons why people get hurt in the gym. So it's vitally important they understand the injury mechanisms or why people get hurt in the gym. If we don't understand why folks are getting hurt in the gym, it's going to be very hard to rehabilitate those folks because let's say we do get them better, they go right back in the gym and get hurt in the same exact way they hurt before. The other piece is if we want to keep these folks safe for the long haul, we have to understand the main reason why these folks get hurt in the first place so we can keep them in the gym training as safe as possible and minimize that risk of future injury. Next, we go over 4 simple steps for getting your clients out of pain. Now, rehab can be very complicated. There's a lot of systems out there that make it very challenging to figure out how to work with your patients. However, it really doesn't have to be that complicated. So I go over 4 easy steps you can follow to get your patients out of pain and back in the gym where they belong. Lesson number 4 is how to build the career of your dreams and earn the respect of your community. Let's face it, the reason why you take these educational courses is obviously so you can learn a little bit more, but really the deep-seated reason is because you want to have the respect of your community. You want your clients to come in, work with you and say, wow, Joe was great. He did a phenomenal job with me. Tell their friends, and their friends come to see you. And after a while, you're very valued and respected within your community. So I'm going to teach you how to do that. The second piece is that if you know these skills, it doesn't always mean you have a ton of patients going through the door so you can work with the population you want to work with, right? So you may be the absolute best coach in the world, but no one wants to come and see you because they don't know who you are and they don't know how good you actually are. So we'll teach you how to get the patients through the door that you want to work with. And lastly, we'll talk a little bit about the Fitness Pain-Free certification. This is the largest and most comprehensive educational course that I offer, but more on this later. So I'll leave a link in the description, in the show notes. Again, it's 100% free, really easy to download. Go ahead and do that right now.
All right, now a little more on incidence in prevalence. And I thought these studies here were pretty cool. So these were out of, I believe it was Norway for one and the Netherlands for the other. I forget which one was which in terms of elite and non-elite athletes because they were looking at, one was looking at elite, one was non-elite. And they were looking at the rate of symptomatic patellar tendinopathy in these 2 groups. I think in the elite group, it was about 50 or so athletes. In the non-elite group, it was somewhere in the 800s, so a little bit better number. And really the point here, I'm not going to go through each and every single one, but what you'll see if you're watching this is that for all the elite athletes, they have significantly higher rates of symptomatic patellar tendinopathy than non-elite athletes. And I thought that was interesting because I think this shows that the higher you're loading the patellar tendon with the more skilled and higher level competition is you're loading the tendon so much more, you're more likely to get patellar tendinopathy. So again, I won't read through every single one, but I think a quick example is we see in professional volleyball players in this group, 45% of them had symptoms of patellar tendinopathy versus the non-elite cohort only had 14.4%, with symptomatic patellar tendinopathy. So, that's like 4-ish times higher in the group who is elite, right? So we see that as you're training more, you're getting more and more jumping cycles, you're probably more likely to get this thing. And then we do see, this is kind of interesting. This study floats around quite a bit if you look at patellar tendinopathy research, but there was a study showing that up to 90% of NBA players show tendon changes on imaging. So that sport, obviously, you're very explosively running, cutting, jumping, really loading the tendon at those high strain rates, and you get degenerative changes to the tendon. And like we said earlier, that doesn't mean you have symptoms, but it does definitely, it seems to predispose you to getting patellar tendinopathy. You're more likely to get it. So I think, takeaway is that those more elite athletes training at a very high level, they're loading the tendon so much more. They're probably at higher risk of getting it. We don't see this so much in non-elite athletes. I mean, we do, but I think the lower the level of competition, probably the less likely you're going to see this versus that higher level.
Not to get too much on a soapbox, but I think Kevin and I were just talking about this last night. In the social media world, you have a lot of prominent folks saying that imaging doesn't matter. And I think for a lot of different pathologies, maybe that's has some truth to it. But I think that in studies like this and in this population, up to 90% of those basketball players are going to have tendon changes via MRI, and a third of them are going to have symptoms associated with it. So it does seem as though having tendinopathy can correlate with eventually having pain. And you're certainly seeing that in this population. So I do feel that imaging is warranted in some folks, right? So because people have tendinopathy that can be asymptomatic, again, doesn't necessarily mean that it can't be symptomatic. And I think the problem is that we may tell our patients it doesn't matter, when in reality, in this case, it really probably does. And it will potentially dictate your treatments, right? If they find some calcific tendinopathy, maybe thinking more about 10X, maybe we're starting to think more extracorporeal shockwave therapy. It does help to guide your clinical reasoning. So we could talk about that all day. I just wanted to note that and show how it's another example where imaging is probably relevant.
All right. And then in terms of risk factors for patellar and quad tendinopathy, we do see this is one condition where males tend to get these types of tendon pains a little more frequently than females do. And there was one study that had about 2,200 athletes, and they were made up of 25% male and 13% female. So those were the numbers of people who had tendinopathy. So about double for men in that study. And this was confirmed by 2 other studies, which showed that men suffer from patellar tendinopathy at rates about double that of women. And what I saw for kind of the author's speculation is that perhaps it's just that men's quads tend to be a little bit stronger and they're maybe loading at a higher strain rate. So maybe that's why we see that they're a little bit more likely to get these types of tendinopathies. Another risk factor is training volume. So there was this study that showed that participation in sports is a risk factor for who's going to develop tendinopathy. And I think that's totally true. We don't really see sedentary folks getting tendinopathies too often unless there maybe is some systemic thing going on. And then elite athletes who train over 12 hours per week had higher rates of patellar tendinopathy than non-elite athletes who train 4 to 5 hours per week. So, just all those exposures, this is definitely an injury that you see more commonly with those exposure hours going up. And then there was one other study that was looking at the amount of jumps performed by volleyball players throughout the course of a season. And the team was practicing a similar volume of hours, right? So they look at how many hours are they practicing in the season, and folks on the team, obviously they're training together, had similar amount of time practicing. But when they actually look at the number of jumps of the people who are getting tendinopathy and those who aren't, there was a statistically higher jump volume in those getting it. So just another thing to consider, right? We see high workloads, higher risk of this type of injury. So pretty interesting.
A couple things to add. So for one, it makes total sense. The reason why Kevin gets injured frequently is probably because he's too strong.
Too strong, especially my quads.
very strong quads, lots and lots of knee pain. Secondarily, you kind of noted something about this, but patellar tendinopathy is interesting to me because if you look at other forms of tendinopathy, so I think rotator cuff tendinopathy is probably the biggest example, but also Achilles tendinopathy. The rates tend to go up as you age. So as you get older, more and more of this pathology starts to occur. Patellar tendinopathy is a little weird. There's kind of like a sweet spot of when patellar tendinopathy occurs. And once you get past that sweet spot, so maybe somewhere between the ages of like 15 and 30, the prevalence goes down. And it maybe speaks to the specific nature of maybe jumping in certain sports. It creates more patella tendon issue, whereas just living life in general seems to be a little more stressful on the rotator cuff. Just speculation, but that's something you probably will see. More folks that are younger having more patellar tendinopathy, and then they kind of almost age out of it. Although this is anecdote, I still continue to see it with older adults. It's just that that's generally when they've had it in the past. It tends to kind of pop up again. But that's an anecdote, just something I've noticed.
Yeah, and then a little bit more about risk factors. So we do see that sometimes in folks who are on certain medications may be at higher risk of developing tendinopathies. So I think like Dan just said, totally in the younger population, you probably see people doing more activity than they do when they're older, more likely to get this thing. But in some older folks who may be on a statin to help lower cholesterol, we do see statins might predispose people to developing tendinopathies of all types, not just patellar and quad. And we do see a little bit of a correlation between obesity and developing this type of tendinopathy. So maybe something to consider outside of the realm of the elite athletes. And then just a quote that I thought was interesting from a study looking at tendinosis, so the changes in the tendon. And the authors examined 54 professional soccer players before and after a season using ultrasonography to look at the tendons. And patients with asymptomatic tendon degeneration, they were at significantly higher risk of developing a symptomatic tendinopathy. So this just goes back to what we were saying a couple slides ago, and I think Dan had made a good point. Sometimes the imaging does matter. And in this case, maybe if we, hypothetically just thinking through here, if we see someone and you're in this setting where you really have access to this imaging and someone has, a pretty significant change in their tendon, maybe you're a little more cautious about how you're training going into the season. Maybe you're doing a little bit less volume of jumping because we know that's something that can be problematic for folks and cause them to develop patellar tendinopathy. So we can use the knowledge about the imaging to modify their training programs. So hopefully they can make it through a full season without getting these symptoms and having to lose time on the field. And then very similarly, another study showed that 141 asymptomatic athletes at the beginning of a season who had hypoechoic, I think that's how you say that, areas of neovascularization represented a risk factor for developing patellar tendinopathy. We know that when you have new vascular tissue in an area of a tendon, that is one of the changes we see in tendinosis. We see more blood vessels, more nerves. So this is showing a very similar thing. When we see these tendon changes, a lot of times these folks are the ones who are at higher risk of developing tendon pain throughout the course of a season. So just again, cases where imaging may matter, and maybe there's a way we can modify training programs to stay on the field or, staying able to play.
Kevin, I'm going to have to agree to disagree here. I don't think imaging matters ever. Okay. Kidding, right? But obviously you can see where this is an instance, right, where it is important. And I talked to Rob Mansky about this like a week or so ago. And one of the things they do is they'll ultrasound, let's say, a rotator cuff and see it's progressing over the course of time. And then you can use the information to decide whether or not someone needs surgery. I think it's very reasonable to use something like ultrasound, which is a bit cheaper than an MRI, for your athletes, let's say in their off season, and then try to track these changes over time. And then you can probably change their training volumes, load, so on and so forth to help to minimize that risk. I mean, in NBA, you have these athletes getting paid millions of dollars. An ultrasound is not that expensive in the grand scheme of things, but missing multiple games is. So I can see, at least in that situation, where it's really important. For the average person, do they need this? Maybe not. But having an ultrasound would be kind of cool if we had in a clinic. It's not that expensive or doesn't take too much time. It might be worthwhile to utilize that diagnostically if you have access to it.
All right. And then just a couple other risk factors without the most firm evidence, but I think just things to consider if we're looking at things maybe we can work on in the clinic a little bit. Some studies were showing a decrease in ankle dorsiflexion range of motion. And this makes sense to me intuitively, right? Like if you're one of Dan's weightlifters and you kind of lacking this motion, but you're doing a bunch of squatting, the motion has to come from somewhere, and you might pick up more motion at the knee. Perhaps that's loading the quad tendon a little bit more. Decreased quad and hamstring flexibility seems to be something you see off and on here. Greater jump training volume, greater counter movement jump height. So perhaps if you're just a better athlete jumping higher, we might be a little more risk. Number of volleyball sets played per week, again, relating to volume, and greater volume of training. So, yeah, I mean, we're seeing this in some papers, and then, I think it makes a lot of sense intuitively. So just things to consider. You might not see that in every single study, but important things that maybe we can try to modify and see how it helps the person in front of us.
Yeah, research like this, these are kind of the articles you can cherry pick to just like kind of push your confirmation bias. Like for me, ankle dorsiflexion, weightlifting seems to be really important and prominent. But what I will say is that knowing that this is mixed evidence has kind of led me down the pathway of chasing other interventions first. And these are more kind of ancillary things. Although from a critical reasoning perspective, I think you can easily, make the assumption that, all right, this person is an Olympic weightlifter. They're lacking ankle dorsiflexion. Having that would improve their lifts, obviously. Might also maybe reduce pain and maybe future problems. So it does make sense. But again, it's conflicting evidence. So it's important just keep that in mind.
All right. And then just kind of wrapping up with a little bit of the pathoetiology. So what's happening in the tendon. And just reading a bunch of different papers on this, one thing they were all saying is that we still don't really know what is changing in the tendon that's causing this pain. We do see some consistent things over time. But like, when does the tendon with a certain structure hurt and when does it not hurt? Kind of hard to say. So despite ongoing research, there's no consensus on tendon pathoetiology, and the complex relationship between tendon pathology, pain, and function is incompletely understood. That's just a quote from one of the papers I cited. But there are common things that we do see in these tendons and what can happen. So we do see kind of increased number of tenocytes, so those tendon cells in the tendon. The tenocytes are a little bit different in structure, so we see a change in the morphology. You'll see a disruption in the collagen fibers, increase in the non-collagenous matrix. Fatty infiltration is definitely something that seems to be in the research over and over. As I said a couple minutes ago, you might see a new growth of blood vessels and nerves in the area. There are some inflammatory mediators. So we talked about how, we got away from the term tendinitis because it's not primarily an inflammatory condition, but you do see some of those inflammatory cells in the area. And then these chronic painful tendons, sometimes you see more of a substance P, more glutamate receptors. So, there are some things that we can be on the lookout for. If we are doing any imaging of tendons or getting any imaging and we're getting these results, we can understand them. But, this will keep changing over time, I think, as we learn more and more about when does a pathological tendon become painful and how does that affect function. So be interesting to see how this progresses in the coming years. Yeah. And then, finally, just a little bit on prognosis. We can definitely treat these things successfully. So one thing that's important to understand is that recurrence rates are high. And then just a couple statistics here. So male athletes from 9 different sports were examined, and the mean duration of symptoms, pretty wild, 32 months plus or minus 25 months. So do the math there. That's a lot. And then another paper was showing that the range could be between 1 and 144 months. So basically, I think I just use this information to tell patients that um, depending on how long it's been going on, I think it kind of gives me some idea of how long this might take to calm down. So if you have someone with a 7-day history of tendon pain, hopefully you can make some changes and kind of nip this thing in the bud relatively quickly. But if you have someone coming in with patellar tendon pain who's had it off and on for years, it's unlikely it's going to go away in a week, right? They have to understand that even if you're doing all the right things, just be prepared that this could take several months, in some cases a year or more. But as we'll talk about in the treatment podcast coming up, working through some pain is okay, and we have to be ready to educate our patients on that. So let them know that this will get better, but it can totally take some time, and we got to be prepared for that.
Yeah, Kevin, I think you kind of nailed it there. That patient education part is going to be really important. We don't want to tell folks that it's not going to get better quickly, because it certainly can. I think one of the issues with a lot of these athletes, they're playing sports. Oftentimes they're playing it year round. They don't have enough time to offload. These tendon problems oftentimes occur in the middle of the season. They finish up that season, maybe have a little bit of time to deload. They go right next to the next sports season, kind of pops back up again. So we're trying our best, obviously, to treat those, but maybe some education about how sports affects this and planning for the long term becomes important. And also probably important is that just giving that expectation, like this is probably going to pop up again in the future. We need to know how to handle it when it does. So let's try to be proactive as much as possible, but there's a dang good chance it's going to pop back again sometime in the future. Okay, so Kevin just gave you some great information about patellar tendinopathy. That is a form of anterior knee pain, but it's not the most common one. The most common one is patellofemoral pain, and we need to know how to diagnose that one as well. So above Kevin's head, right above his dome, he's pointing at it right now, there's going to be a link. And in that link, I want you to click on it. We're going to go over everything you need to know about patellofemoral pain. So click on that link, and I'll see you there. If you're watching this on YouTube, please hit that like button. Consider subscribing to the channel if you enjoy this. If you're listening to the podcast version of this, please give me a 5 out of 5 rating. It helps tremendously. And lastly, if you want to go that next step and support me further, consider subscribing to Fitness Pain Free Insiders. So Insiders is like Netflix for physical therapists and coaches working with painful folks in the gym. You've got access to 100 plus webinars, ebooks, and courses. More recently, I've been taking all of my best content from YouTube. I've been taking out all the ads. I've been organizing it in a really step-by-step fashion in an entire course so you can easily go through it. And I add additional pieces to this to enhance your learning, right? So I just finished up my lateral ankle sprain course. And one of the big things I add to this was a protocol. So essentially, what do you do week 1, week 2, week 3, week 4, week 5, 6, 7, 8? You know me, I like working with athletes. I like working with really fit and strong people. So it's going to be a lot more robust than your typical protocol. Also, you have access to me. So inside of Insiders, you can leave a comment and I'll get right back to you. I also have physical therapy CEUs inside of Insiders. So if you take the course, Essential Coaches Series, get a bunch of CEUs. And what's even better is you can start for just $1. After that, it's $25 per month. It's going to be the cheapest CEUs you can get. It's by far the highest value program that I offer at the cheapest price. So head over to fitnesspainfree.com, click on the program's link, and then click on Fitness Pain Free Insiders to get started. I'll also leave a link in the show notes where you can check it out.